I'm very happy, and that was model-informed precision dosing was introduced nicely there by Tony, but we're actually going to have a wonderful presentation next from Dr. Jefman Efendi, who's a clinical pharmacology physician at Ubaya Hospital and also a lecturer at the Facility of Medicine, Universitas Surabaya, Indonesia. He currently serves as the chairperson of the Indonesian Association of Clinical Pharmacology Specialists, and he is driven to bring personalized therapy services to Indonesia, including optimized antimicrobial treatments for better patient outcomes. So, terima kasih, welcome, and take it away.
Thank you, Amy. So, thank you for having me in this webinar. For the introduction, so this where I come from. I come from Indonesia, the Surabaya. You see, my slide is moving, right? Yeah. So this is the University of Surabaya, Faculty of Medicine, University of Surabaya, and this is my hospital, Ubaya Hospital. Just walking from the faculty to the hospitals. So for the background, it's in the early 1970, the scientists start to measuring drug concentration in human to reflect the drug disposition in the body. But we know that the disposition of drug disposition in the body is determined by absorption, distribution, metabolism, and excretion. And we also know that the ADME could affect by several factors or covariate like ages, body weight, organ impairment, pharmacogenomics, comorbidities, drug interaction, something like that. So the need for the interpretation for the concentration should be interpreted in the context of individual patient factors. So how we do that? So for the conventional TDM sampling, the sampling should be taken in its steady state to reflect the patient, the exposure of the drug. If we want to measure or measuring the exposure, the total exposure of the drug to the human body, we could use the trapezoidal methods, but it quite challenging because it needs multiple samples and costly, of course. Then we do the conventional TDM to use the single drug concentration like C-trough, but this is potentially suboptimal for surrogate of overall drug exposure. Like Sebastian Vicha and friends show us, they make a simulation how single drug measurement in terms of C-trough could lead to misinterpretation of total drug exposure. So we need to if we need to calculate the AUC with the few samples of drugs measuring concentration, or few samples of the drug concentration, we need a mathematical models approach to simultaneously integrate the patient covariates and the drug concentration by using the posterior prediction or Bayesian forecasting approach. So with MIPD, we could we could calculate the AUC with a few samples. So how about the Indonesian context? In Indonesia, based on Institute of Health Metric and Evaluation, there were estimation about more than 30,000 deaths attributable to antimicrobial resistance, and more than 140 deaths associated with AMR in Indonesia. So our colleague from microbiologists in Indonesia, they are collecting the data from WHO priority pathogen prevalence from 75 hospitals in Indonesia. That you see the MRSA prevalence is more than 30%. And this is the susceptibility of drug for MRSA in Indonesia. As you see in the slide, that vancomycin still be the first choice to treat MRSA in Indonesia. the linezolid it's quite difficult to access in Indonesia due to cost. The high cost of linezolid is too high in Indonesia. So, but the problem is at this moment we have no TDM service for vancomycin available in Indonesia yet. So how we utilize the vancomycin? So I presenting the first case, 70s, 70s, 70s and 90s. Sorry, a 67 years old male patient was admitted to the hospital with diagnosis of non-hemorrhagic stroke, pneumonia, and chronic kidney disease. The patient has previously been treated with ampicillin, sulbactam, and levofloxacin, but his condition worsened, and he was subsequently admitted to the ICU, placed on ventilator, and culture examination results show the growth of Rotia christinae. Even we see the many susceptibility of the drug, but literature said that vancomycin should be drug of choice to treat Rotia christinae. The patient experienced leukocytosis and increase of the creatinine. So we think, how could we treat this patient with vancomycin? We choose this regimen, loading dose with 1,000 milligrams. We use maintenance dose 500 milligram twice daily. And then in third day of vancomycin treatment, the patient is clinically deteriorating. Even though the creatinine is go down, but we think what should we do? So we don't have. So what I say, what I present here is not the standard practice actually, but we try to use the model informed processing dosing software. I use precise PK. We want to know the population, the possibility from the population data for this patient. Maybe it could help us to guide us to getting the dose. So when we are calculating the IUC of this patient is around 400. In the literature said that sometimes we need to increase the IUC of vancomycin to 500, more than 500. So we decide to increase the vancomycin to 500 milligrams twice daily. And then based on the precise PK or model informed processing dosing software, we just estimate the population data. It's maybe the IUC for per MIC, it's around 500. So after that, we continue the vancomycin treatment for 3 daily, and then patient at 7 days treatment of vancomycin, the clinically stable, vancomycin was stopped, and then patient transferred to low care unit. 2 days later, patient discharged. The second case, 37 years old female, patient was admitted to ICU due to sepsis and respiratory failure. The patient had previously undergone VP shunt for hydrocephalus, after which she developed aspiration pneumonia in the ward. She was administered empirical therapy with metronidazole and ceftazidime based on the culture results. 3 days later, blood culture results revealed the presence of Staphylococcus hemolyticus. So as we see, the MIC of the vancomycin is below 1.5. The patient experienced increased the creatinine 1.07 and prompting consideration for vancomycin administration with dose adjustment. So we choose this regimen again, loading dose with 1,000 milligrams, maintenance with 500 twice daily. And then we try to simulate the MIPD, maybe the IUC per MIC around 600. So it we could attempt the PKPD target, but this is for the population data. So after 6 days of vancomycin treatment, we stop vancomycin, and then patient discharged after 32 days of hospitalization. But vancomycin MRSA case in my hospital is not so high. For 1 year, we only face 5 cases of MRSA. So the MRSA is quite low in our hospitals. For second Indonesian context, we know that in Indonesia the kidney transplantation is start rising. So if the patient got the recipient got the if the transplantation patient they need immunosuppressive agent like tacrolimus. Uh, from the IATDMCT consensus, they say that we have to achieve a target for tacrolimus level for the transplant patient. Before 2025, the tacrolimus level concentration in Indonesia is conducted, but just measuring the concentration, not TDM. So no TDM service yet in Indonesia before 2025. And then in the we start a study to know how about the achievement of the CTROF of renal transplantation in Indonesia. This is our study. We just included 9 patients of the patient of renal transplantation, and we found that the actual concentration of tacrolimus when we simulate it or calculate using the model info processing dosing software, we know that the more patient has low concentration or the concentration of the patient is majority below 5 nanogram per milliliters. Why this happened? This because the pre-analytical issue should be improved in Indonesia setting for the tacrolimus level measurement. So based on this data, we standardize the pre-analytical and post-analytical aspect, and then we introduce the TDM service in one hospital in Indonesia. So this is the third case. A 62 years old patient with history of renal transplantation since 2017. Uh, Present with outpatient clinic routine follow-up. 6 months ago, the patient's tacrolimus level was 6.7 nanogram per milliliters, with a history of tacrolimus dosing at 1 milligram on odd dates and 2 milligram on even dates prior to the measurement. So the clinician or the nephrologist asked the patient to reduce the tacrolimus dose to 1 milligram every 24 hours. 3 months later, the tacrolimus level was found to be 12 and 6 nanogram per 12.6 nanogram per milliliter. The dose was further reduced to 0.5 milligram every 24 hours for the past 3 months. After that, after initiating the TDM service, the nephrologist sent the patient to the clinical pharmacology polyclinic for tacrolimus level monitoring and dose adjustment for TAC level target 6 nanogram per milliliters. So this is the patient's data. So if you see the first two concentration, we have the limitation to interpret the data because of the pre-analytical issue. But in the other hand, when we see the increase the level of tacrolimus to 12.6 at the second measurements, it's also maybe due to drug interaction, due to the food drug interaction, because the patient is using mandarin orange for daily consumption for last 3 months. So after the patient referred to me, and then we are checking the concentration. So we got the concentration is 3.5, 3.9, 3.6 nanogram per milliliter for the trough level. And then we try to simulate the patient on the model informed processing dosing. And as you see, the concentration that measured the last two concentration, the 12.9 concentration is quite high for this patient. So it indicate this patient experience of food drug interaction. So after that, we change the regimen of the tacrolimus, going to 1 milligram once daily to achieve the CTROF 9 nanogram per milliliter. So this is also there is also a study about MIPD for tacrolimus kidney transplant patient, but we are still waiting for the publication of this study. So take-home message, MIPD is a potential tool to guide the optimization of vancomycin and tacrolimus therapy. Integration with the therapeutic drug monitoring is need to ensure precision dosing, enhancing efficacy and minimizing toxicity. We need more data before adapting MIPD in clinical practice as standard of care in Indonesia. So for my last slide, I would like to say thank you to RATS TDMCT committee, the Ubaya Hospital ICU team, tacrolimus studies team, and tacrolimus TDM service. Thank you.
Bagus sekali, terima kasih. That was a wonderful MIPD overview, and I think a lot of the Australian pharmacists will be panicking, thinking about trying to do vancomycin without TDM. But you've shown that you can really use MIPD to help make good decisions in the absence of TDM, and it probably really hones your skills about having that, strong clinical review as well.
Yeah, thank you.
Does anyone have we do have a couple of minutes if anyone's got any burning questions they want to put into the chat or the Q&A. I will just ask quickly, you mentioned you've been using Precise PK. How do you find using it? Do you find it quite user-friendly?
Yeah. For me, I have using several MIPD, but Precise Speaker is quite user friendly for me. The user interface is very good.
Yeah, okay. Yeah, that's great. Tony mentioned he used Insight RX, and I must say, I pretty much exclusively use TDMX or IDODS, and then you use Precise PK. So it does just go to show that there's lots of different ones out there that you just got to find the one that suits your best, maybe.
Yeah.
Okay, no one in the room wants to ask any questions. All right. Well, we might. Thank you very much. Please feel free to stick around in case there's questions at the end. But if you do have to go, I understand you're very busy. We're very grateful for your time.